Good morning, everyone. Thanks, Camille, so much for the invitation to come share my thoughts on cardiac rate and rhythm disorders with you all. This has been a pleasurable experience to do every year. I'm really happy that you asked me to come back. So the objectives of today's talk, understand arrhythmia epidemiology, recognize a typical clinical scenario for arrhythmia presentation, review common causes of sudden cardiac death, and then we'll talk briefly about pacemaker basics in the end. So let's first start with the term supra-ventricular tachycardia. This is something I'm sure you're all familiar with. When I think of supra-ventricular tachycardia, I try to split up that disease pathology into two categories, essentially. One is the pathology that's AV nodal dependent, and the other is the pathology that's AV nodal independent. And of course, the AV nodal dependent types of SVT are AV NRT, which stands for atrioventricular nodal reentrant tachycardia, and AVRT, atrioventricular reentrant tachycardia. We'll talk about what those mean in a moment. And the AV nodal independent tachycardias are really, there are three, but there are really two that affect pediatric patients. One is ectopic atrial tachycardia, atrial flutter being next, and atrial fibrillation is quite rare in pediatric patients. We're starting to see that a little bit in teenagers, but still in that patient population, it's quite rare. When I think of SVT mechanisms, this is the cartoon that comes to mind for me. If you look up here at the screen, you see here there's this yellow arrow reentrant circuit, and this is used to demonstrate pathway-mediated tachycardia. So you see in this patient, there's an extra pathway here that's not supposed to be there in addition to the normal AV node. And you can have a reentrant circuit between that AV node and between this pathway. And that accounts for a good majority of the SVT we see in real young patients. There's the AV nodal reentrant tachycardia demarcated by this red circle here. And that shows that there is a reentrant circuit within the AV node itself, and that's AV NRT. It's the most common cause of SVT in a teenager or adolescent patient. And then you have circuits within the atrium itself. This denotes atrial flutter. And then this asterisk here showing you that you have an ectopic atrial rhythm, something other than the sinus node that's firing and taking over the electricity of the heart. So all these are lumped into what we know as SVT, but of course the mechanisms, the epidemiology, the treatment, all of those things are quite different. So what is our approach in assessing patients like this? So once we've defined that it's a narrow complex tachycardia, I like to further define the mechanism of that tachycardia by saying whether it's a reentrant circuit versus an automatic circuit. So in reentry, it tends to have these typical categories, and reentry circuits are the more common of the subtype. They're paroxysmal, meaning that they're rapid onset, rapid offset. So when we interview patients and ask them about their symptoms, we want to know first, how did it start? And a patient will typically say, I was sitting in math class, minding my own business, when all of a sudden my heart rate started racing. That's when you know this is not only an arrhythmia, but this is likely a form of reentrant tachycardia. The heart rate tends to be fixed. So when you see these patients in the ER, their heart rate's 250 and doesn't budge a bit. The heart rates tend to be fast, so unlike arrhythmias that are automatic, which we'll see in a second, these heart rates are a lot faster. These circuits tend to go a lot faster. Little babies can be up to 300 beats a minute, and older children can be 250 or even more. So the real fast tachycardias tend to be reentrant. And for that reason, because they're fast, because it's paroxysmal, patients tend to feel it. So you would imagine if your heart rate's totally normal, then all of a sudden it goes up to 250 beats a minute, that's not going to fly under your radar. And most patients that can communicate, patients that are older than 4, can let their parents know or let somebody know that their heart rate's going really fast. So it's very unusual for a patient to have this type of arrhythmia and no one know about it, them never present, for this to kind of fly under the radar. And for that reason as well, it's a rare cause of cardiomyopathy. So these patients tend to get this either treated or it goes away on its own. They're not going to linger in this for hours and hours and hours, unless, of course, it's a real young baby that can't describe symptoms. And if you look at heart rate trends graphically over time, you'll see, again, The telltale characteristics here is that there's abrupt onset and abrupt termination, and then at the top here you see that there's a fixed heart rate with no variability. So let's contrast that to the automaticity or the trigger type of arrhythmias. These tend to be incessant, they're often hard to control, the heart rates tend to be variable, so there's not that fixed heart rate that doesn't budge that you see in re-entry. They tend to be a little bit slower, and patients, for that reason, may or may not feel that they're in a tachycardia. So if your heart rate's typically 80 and it goes up to 110, a pediatric patient may not necessarily recognize that their heart rate's a little faster, and they may be asymptomatic for quite some time. Because they don't involve the AV node as part of the circuitry, vagal maneuvers usually don't work. And they can cause cardiomyopathy because, again, patients may or may not know that they have this tachycardia in the first place. And when you look at graphic trends, you see that there is this gradual onset, gradual offset to the tachycardia. Again, patients may or may not feel that. So let's start with a 1-day-old in the NICU. This is a patient that we were consulted on that was at Hillcrest with irregular narrow complex tachycardia. When we look at ECGs, particularly as an electrophysiologist, the one thing I want to know in a narrow complex tachycardia, really any tachycardia, is where are the P waves, right? The P waves give you a huge clue as to what the mechanism of the tachycardia is. And sometimes it takes a trained eye to find them, but if you blow up this picture, for example, you see that there are little tiny negative P waves right after the QRS here that are denoted by the red arrow. So what type of tachycardia is this? It's a regular narrow complex tachycardia consistent with SVT. What do we know about the age distribution when you have your first episode of SVT? So most patients with their first episode of SVT, 2/3 of patients have their first episode when they're less than 1 year of age. So 66% of pediatric patients will have their first episode of SVT when they're a baby, when they're an infant. And then there's a smattering of patients that have SVT when they're older, some when they're more than 10, a handful when they're 1 to 5 years old, and then there's sort of the early school children that have first onset of SVT. The majority of the time, patients that have SVT have it early. So why is that? This is a study done by Hiraj about 10 years ago that cross-sectioned patients that had fetal demise at different ages gestationally. And they looked at the hearts in cross-section. And when you cross-section a fetus's heart, you'll find that within the atrioventricular groove, so where the AV valves are supposed to sit, in normal people is an area where there's no electrical connection, unless it's the AV node. There's not supposed to be electrical fibers that traverse the AV valves. What we find in infants, and particularly in the youngs that are the ones that are very, very small in gestational age, is that some of those connections exist. So what, as we all know from embryology, heart starts off as a big glob of cells, and when that cells differentiate and the heart septates, it pulls muscle tissue north in the atrium and south in the ventricle to the point where the valves form in the middle and there's no more ventricular myocardium or atriomyocardium that connect the top chamber and the bottom chamber. What happens when you're really, really young, of course, if you're a 22-week preemie, is that septation hasn't fully happened yet, and you may have some strings of tissue that are still connecting the atrium and the ventricle, and that's exactly what an accessory pathway is. When we teach the residents about this phenomenon, the closest analogy I can think of is think of a pizza pie. You have a pizza pie, somebody cuts the pizza pie and you scoop in there to get a slice of pizza. What happens to the slice of pizza? It's still stuck onto the pizza pie by these little strings of cheese. And as you pull, then those strings snap and then you have your free pizza slice. This is the same thing that happens embryologically with the heart when it's septating. The natural history of SVT is a really important concept as far as understanding what happens to these patients after they leave the NICU, after they have their first event in the nursery in the NICU. What do we expect? And there was a study done by Jim Perry almost 20 years ago now that shows the concept of early disappearance and late recurrence, meaning that if you have the age of onset of your tachycardia when you're 0 to 2 months old, the probability that it's going to go away on its own is 60 to 90%, and the probability of recurrence is about 30%. Whereas if you have your first onset of tachycardia when you're greater than 5 years old, the probability that it's going to resolve is a lot less, at 25%. So when we counsel patients, if baby boy Stuart has a SVT in the NICU a day of life 1, so there's a pretty good chance that your SVT is going to go away after a year of age. We oftentimes will treat them for that year, particularly knowing that it's hard to assess a baby in tachycardia at that age. They can't tell you they're in tachycardia. When they're past a year, the parents become quite comfortable with noticing whether they're in tachycardia or not. We can stop the medicine and say, let us know if little junior has SVT again. Whereas if somebody's greater than 5 years of age, the probability that their tachycardia is going to go away on its own is a lot less, and oftentimes we'll tell the family, this is probably here to stay. We should probably think of medical therapy or other therapies for long-term for this patient. Acute SVT treatment, of course, vagal maneuvers first, then adenosine. You know, there's a couple of pearls to taking tests, and oftentimes if you see an answer that seems non-invasive and not harmful, it's usually the right answer. So if somebody's in SVT and they give you a bunch of options that require doing something bad to a baby, and one of them is putting ice on the baby's face, then maybe you should put ice on the baby's face, right? So vagal maneuvers are always the place to start. If vagal maneuvers don't work, then adenosine. This is, you know, if there's anything I can teach you today, this is just about the most important thing. So run a rhythm strip. You always have time in a baby that has SVT. I could think of an exception maybe on my single hand of times where you don't have enough time to get a rhythm strip. But you nearly always have enough time to get a rhythm strip in a baby that's in SVT, where you can run the rhythm strip while you're doing an intervention like giving adenosine. So we as electrophysiologists, Dr. Sorrell over there is in the back, I'm sure, sympathizes with my plea here. We can look at those rhythm strips later and figure out what the exact mechanism of that tachycardia is. And that certainly helps us a lot figure out how to treat that patient prospectively. But take the time, get a 12 lead on, particularly if you're in the ER, you're very well cushioned in terms of being able to deal with events in that place. Use the resources you have and get a nice study with a 12 lead. And there's also, so vagal maneuvers and adenosine tend to be maneuvers that will control the rhythm, stop the arrhythmia. There's also the impetus of wanting to slow the heart rate down. So if somebody's in tachycardia and they're unstable because they're fast, you can give them medicines to slow the rate down. Those tend to be beta blockers. Calcium channel blockers work, but we tend to reserve them for our older patients. As a matter of fact, calcium channel blockers in infants are contraindicated. So that's never the right answer to give a calcium channel blocker to an infant, because your myocardium is very calcium dependent, and when you block the calcium channel, they can have cardiac arrest and cardiovascular collapse. And cardioversion is reserved, of course, for the unstable patient. And in the years of practice that Dr. Sorrell and I have had, it is pretty uncommon that you need to cardiovert a patient that's not a post-op in the ICU. So if somebody's coming in the ED, they're usually coming from home in a car, and you typically have time to figure out what's what. Give them vagal maneuvers, get a 12 lead. Rarely would you have to cardiovert somebody in SVT. Here's another clinical scenario. This is a 14-year-old patient, palpitations. Described as sudden onset, sudden offset. So right away your brain's thinking this must be some sort of reentrant mechanism. The patient tells you it lasts for 10 to 20 minutes. It occurs about twice a week. The patient feels dizzy and lightheaded but has not had a syncopal event, and they present to your office. The first thing you want to get, of course, is an EKG, right? So you get an EKG on the patient and it shows this. I promised the residents I would pimp them. So any residents in the room know what this might be? Starts with a W. Ends in a W. This is WPW. So this is Wolff-Parkinson-White syndrome. I know it's probably hard to see this way out in the back, and that can be your excuse, I suppose. But this EKG shows a short PR, a wide QRS, and a nice delta wave. This is a pretty classic EKG for a patient with WPW. WPW is a different beast, and we'll see why in a second. So this is a cartoon drawing of what WPW is. You have a normal sinus node like everybody does. You have a normal AV node like everybody does, and a normal His-Purkinje system. When impulses come down in a normal patient through the AV node, the impulse gets slowed very, very briefly in the AV node. And I think this is a protective mechanism for the ventricle to not be very fast when you're in atrial arrhythmia. But at any rate, this slowing of the AV node causes that flat segment of the PR. So the P wave happens, nothing happens, then you have a QRS in a normal patient. That nothing happening is delay in the AV node. If you add an accessory pathways tend to be stupid and immature. When they see electricity, they say, go, and they send it right down to the ventricle without slowing it down. And that's what causes the delta wave and the short PR. The ventricle's activating before it's supposed to in the normal AV node. There's no slowing of that electrical conduction in the AV node. The accessory pathway just lets it go as fast as it can. So what do we see with these patients? It's a pathway with antegrade conduction. We find three things: a short PR, a wide QRS, and a delta wave. And this leads to really two clinical problems. One is what we would call SVT, the normal reentrant tachycardia using a pathway. So it goes down the AV node and up the pathway in a reentrant circuit. We'll see that in a second. And the other one is the life-threatening one. The cause of sudden cardiac death is about 0.5% to 5%, and that's caused by rapid conduction of an atrial arrhythmia in a patient with WPW. So first, we'll start with the more common subtype. This is a pictorial of reentrant tachycardia. So what you have here is a patient with WPW. This is a premature atrial contraction. So what happens is a PAC comes in, it ends up blocking down the pathway, so you have a narrow beat. It goes down the AV node, comes back up the pathway, and goes around and around and around itself. This type of arrhythmia can be treated with vagal maneuvers and adenosine and the like. This causes palpitations, does not cause sudden cardiac death. So patients typically present with this arrhythmia, say, I felt palpitations, I didn't pass out, I didn't die. They come to your clinic like our patient did. Contrast that to this arrhythmia. So this is the same patient that has WPW where you develop something called atrial fibrillation, let's say. So the top chamber of the heart's going like this, fibrillating. All those electrical signals from the top chamber are trying to make it down the AV node, and the AV node's blocking them. The AV node's saying, slow down, slow down, slow down, so the ventricle doesn't go fast. But the pathway doesn't. The pathway says, come on through, it's a party. The ventricle also goes in a party, and that party is ventricular fibrillation, and that's what causes sudden cardiac death. So this is the reason why patients with WPW are at risk for sudden cardiac death. It's how fast that pathway can conduct electricity, and that's what leads to syncope and sudden death in these patients. Fortunately, unlike most of the things that we see in pediatric cardiology, there is a cure to this. We're not just putting Band-Aids on patients with WPW. We can take them to a lab, we can find out where their pathway is coming from, and ultimately we can cure them. And this is just an example of a patient who had a pathway right here in the posterior septal part of the tricuspid valve that we burned. And this is the post-ablation ECG showing no WPW. Yay. All right. Now it's a 17-year-old with tachycardia. This is interesting. So the part of their science class, they were asked to feel each other's heart rates. So this guy's partner leans over to him. He feels his pulse. And he's like, I'm not sure, man, but seems like your pulse is kind of fast. And he's like, whatever, I feel fine, right? The teacher finds out that this child's heart rate's fast, sends him to the pediatrician. And initially, the pediatrician diagnosed him as just having sinus tachycardia, and I'll show you what that looks like. The patient has no other cardiovascular symptoms, gets an echocardiogram, and the echo shows that his heart's actually quite sick. The ventricular function of his heart is depressed. And this is what his ECG looks like, and I pointed in arrows at what the problem is. So the residents and our fellows know this. When you're assessing for whether somebody has sinus rhythm or not, you want to know whether the sinus node is what's actually firing to drive the impulse. If there's something else firing other than the sinus node, the axis of the P wave is not going to be correct. And you see in this ECG, the P wave in lead 2 and lead 3 and in lead AVF is negative. That tells you it's coming from somewhere low in the atrium, not high up where the sinus node lives. And that is a problem. This patient, again, was seen by a pediatrician. They saw a P wave before every QRS and a QRS after every P wave and said, sinus tachycardia. Why don't you go home and relax? You must be anxious, seeing the doctor today. And just to drive that point home a little bit further, the impulse starts here in the SA node, which is high right atrium, goes down the AV node down to the His-Purkinje system. If something else is activating, let's say on the left side, or let's say low, that's essentially an ectopic atrial tachycardia if it's fast. And we found this patient's focus, and it was ablated. And now the P wave axis is up in 2, 3 in AVF and is normal, going from the sinus node. This was a 21-year-old soccer player that was going to college. She was practicing for her college team in Southern Ohio. And during wind sprints, she essentially passed out without a warning, woke up on the ground, turned blue, was thought to convulse a little bit. The coach went to go get an AED, and as the coach is putting the AED on her, she wakes up. She's looking around, wondering what went on. Has no recollection of the events that happened before then. The AED, of course, when she was awake, showed that she didn't have a shockable rhythm. She ends up going to an ED locally. She gets an ECG, and they said everything looks fine, and they cleared her. And she shows up the next day for practice, and her coach says, well, what are you doing here? You just passed out running. Maybe there's something wrong with you. This is the coach, not the ED, saying this. And they end up coming to us for a second opinion, and this is her ECG. This is an ECG that, as an electrophysiologist, if I'm standing in the corner of the room, I say, oh dear, who's this kid's ECG? And there's a huge problem here, and that's that the QTC is really, really long. You guys can probably appreciate that. Hers is 540 milliseconds, so quite a prolonged QTC. Long QT syndrome is an ion channelopathy that causes sudden cardiac death. It's inherited in the autosomal dominant fashion. So oftentimes in a PEDS board examination, they'll say, mom has long QT syndrome, dad doesn't. What's the probability that one of the kids will? And it's 50%, males or females, of course. The hallmark presentation is passing out without a prodrome. So unlike what we'll see with vasovagal syncope, where they feel dizzy, lightheaded, hot flashes, tunnel vision, what have you, these patients are exercising and they wake up on the ground and don't remember what happened. The hallmark arrhythmia is this, which is torsades. The clinical dilemma here, and this is important to recognize, is that the EKG is part of the puzzle. So if I got an EKG on everybody in the room and did a bell-shaped curve distribution of it, this is what it would look like, where all the normal people would have a mean of around 400. And if I took all the long QT people, this is in a Mike Ackerman study, he uses Mayo Clinic cohort. If we took our patients at the Cleveland Clinic, they would have a distribution that showed a mean more like 480, 490. The problem here is that this green denotes the overlap. There are people that we see that are 460 that are normal. There are long QT patients that we see that are 460 that are clearly not abnormal. So how do you just by the ECG alone tell whether somebody has long QT syndrome or not if their QTC is borderline, right? If it's 460, and that becomes the issue. And the good news is that there's a lot more than just the ECG that tells you somebody has long QT syndrome, like, for example, the family history, like the own patient's history. And that's why it's so important to take the ECG as part of the puzzle, not the entire puzzle itself. The other diagnostic criteria, this is really mentioned for reference purposes only, is that there's all these other things that a patient with long QT syndrome could have other than just the QTC, like a history of torsades, TB of alternate, and so on and so forth. Syncope, that sounds bad with stress. They get some points for that. A family history of badness or people with long QT syndrome also gives you points. So that if you have a long QT score or a short score that's north of 3, then your probability of having long QT syndrome gets higher and higher, not just the ECGs involved. And what do we do to treat these patients? We give them beta blockers, but not all beta blockers are created equal. In electrophysiology, we like to use Nadolol usually, but there are lots of patients that come to us as referrals that are on different beta blockers, and we try to switch them if we can. There's also different things about their exercise stress testing that are abnormal, where we can tease out what type of subtype patients with long QT syndrome have. Oftentimes we'll exercise them and find a normal patient at baseline can become very abnormal in terms of the QTC interval when they are assessed in late recovery. So this is one of the tools that we use in addition to all the other ones, EKG, family history, so on and so forth, to figure out whether somebody has long QT syndrome or not. So back to our patient that was running during soccer. She tested for the long QT1 gene, which is the typical gene that causes syncope during exercise. And we gave her the vitamin Nadolol, and she's still on that without any symptoms. The other important piece of treatment for long QT syndrome is avoiding the medications that prolong the QT interval. Typically, in an adolescent patient, it takes more than one hit for them to become symptomatic. So you add exercise on a day where maybe they haven't slept or ate or drank well, and on a day that they're taking azithromycin for a sinus infection, and that's the recipe for disaster. That's how I would cause long QT syndrome arrhythmia in a patient of mine, right? You have to add more insults to the story, and avoiding the ones that we can control for is our approach. This is a 10-year-old male with syncope and a family history of sudden cardiac death. As a matter of fact, this is a patient that came to us from UAE. He was one of 11, I think, siblings, so he had a ton of siblings. 4 of them had died suddenly, and he was the youngest. And when he was brought to us, the family said he passes out, but we think his passing out spells are related to the emotional stress of him losing all of his siblings and not really anything else. He's just a stressed guy who is having detachment issues from the loss of his siblings, and we get this ECG on him. Anybody know what this ECG shows? Shruti, Ben. This is Brugada Syndrome. So you see here that there is this very bizarre looking right bundle branch block in this patient. This is a classic ECG for Brugada Syndrome. Brugada Syndrome is a sodium ion channelopathy. It has some crossover with a subtype of long QT syndrome, but it's the hallmark is sudden cardiac death during sleep. Patients present with syncope, of course, and EKG abnormalities are exacerbated by fevers. Oftentimes their EKGs can be normal at rest. They have a fever, and then their EKGs become very bizarre looking. And we oftentimes, if somebody has a borderline ECG, will request that they get another one while they're febrile. Treatment strategies, really the implantable cardioverter defibrillator, the ICD, has been the only proven strategy to prevent sudden cardiac death. Some practitioners have used quinidine as a antiarrhythmic to prevent arrhythmia, though for the most part there's not great data that shows that prevents much in the way of arrhythmia. You're sort of preventing what happens after the arrhythmia with an ICD. This is a 14-year-old basketball player. This is a patient I saw when I was in Philadelphia. This patient had syncope during basketball practice and was seen by one of our cardiologists, and this is the ECG that we saw. So there's a couple things on this ECG that are huge red flags that there's a problem. One is there are T-wave inversions in 2, 3, and AVF. That's typically an abnormal thing. We can see that in some normal patients, but it's not very common. What's even more abnormal is that there are T-wave inversions on the left side of the heart too. And this isn't the easiest thing to notice, but all the leads are half standard. So when the voltages get really big and you put them on an ECG, they tend to blend into one another, and you can't tell where one starts and the other one begins. But what we did is we smashed all of the voltages in half. So if a voltage is this big, we're cutting it in half to this big. So the voltage here in V6, which looks like about 22, is 44, somewhere up here. And if I showed you guys that ECG, I think all of you would recognize, wow, those voltages look really big. Maybe this is left ventricular hypertrophy, and that's, of course, what we thought, too. This patient actually has hypertrophic cardiomyopathy, asymmetric hypertrophy of the septum. It's autosomal dominant, just like long QT syndrome is. The presentations can be variable. They can have chest pain that's exertional. That's usually a manifestation of ischemia. They can also have dizziness with exercise or even syncope. It is a very common cause of sudden cardiac death by arrhythmia mechanism or by actual obstruction in and of itself. This is a paper by Barry Marin a little more than 10 years ago in Circulation that looked at about 1,400 or so young competitive athletes, and through autopsy examination defined what the cause of death was. And the majority, 36%, were found to have hypertrophic cardiomyopathy, and there's a smattering of other things. My caution in assessing this is, again, this is pathology data. So if you look at ion channelopathies, it's only 3%, but you can't diagnose an ion channelopathy through an autopsy. It's a diagnosis of exclusion. So if somebody has an autopsy and everything looks crystal clear and the story suggested that they had an arrhythmia, they say, well, it must have been a heart rhythm disorder, and maybe it was an ion channelopathy. Not something that you typically diagnose with an autopsy. So this patient was scheduled for an MRI. He presented on a Saturday. He was discharged on Sunday, and his MRI was scheduled for Wednesday. He was restricted from sports, of course, and he and his brother were involved in a tournament that Tuesday. So this is a guy from Philadelphia. And his brother said, hey man, you're getting this MRI tomorrow, we'll figure out what's going on, but today's a tournament, you need to play. So his brother convinced him to play, and he did. And this actually went down in the Hank Gathers Memorial Auditorium. Anybody know who Hank Gathers is? Hank Gathers was a collegiate basketball player. He played for Marymount. He had an alley-oop dunk in a game. After the dunk, he went back to go play defense, collapsed on the ground, and died on the court. And they had a memorial stadium for him where this tournament was being held called the Hank Gathers Auditorium. And Hank Gathers, of course, died of hypertrophic cardiomyopathy. So back to our patient, he's convinced to play in this tournament, and he died on the court in Hank Gathers Auditorium. It's like the thick irony, and it's hard to talk about that patient. This is a 15-year-old with an irregular rhythm. This patient was totally asymptomatic, went for a well-child examination for sports clearance, and his astute pediatrician said, your heart rhythm's all over the place, right? So some people see this and they say, oh dear, looks like there's wide complex arrhythmias here, 4 beats of this wide complex stuff. Here's 5 beats of it. What do you do, right? This is a patient that, from what I can tell here, a wide complex rhythm looks like ventricular tachycardia. And you can also see that the P waves are dissociated from what's going on in the ventricle, which is pathognomonic for ventricular tachycardia. So this is VT. So what do we do with a patient with VT? Well, the patient's alive. The patient's wondering why everybody's getting so excited, right? So what happens in an office is you say, hey, why don't we have one of the residents come check this out? So the resident comes in, the medical student comes in, and now the seemingly healthy 15-year-old kid that's there wanting to play soccer in the fall has got 15 people in the exam room, and he's nervous. He's wondering why everybody's so excited. He has an echocardiogram. That's normal. His telemetry shows that he has non-sustained VT, just like we saw in his ECG. Then he had an exercise test, and when he exercises, his VT goes away. When he recovers, so after he's done exercising, we put him on a chair, we let him relax. 2 minutes after his peak exercise time, still no PVCs. Then 3 minutes later, he has VT. So what do we do now? Same as we did before, nothing. He's totally asymptomatic. He's sitting there on the chair. He has no idea that these arrhythmias are happening inside him, and his heart is totally normal, and his PVC is suppressed with exercise. This is actually a very common thing that we see in pediatric patients. This is an example of right ventricular outflow tract ventricular tachycardia. So this is a benign VT in the setting of a structurally normal heart. The PVCs tend to have a very specific axis because they come from the right ventricular outflow tract. They have a left bundle and inferior axis. They're typically suppressed with exercise. They can terminate with adenosine, no. It's not the most important feature. The most important feature is that it's benign. So we do nothing with these patients. We offer reassurance. We send them on their way. Ooh, this is a 16-year-old with postural syncope. So she was admitted to the hospital because she was in choir class singing and she passed out. And for whatever reason, the ED was concerned about her. They admitted her to the hospital, and she got up from her bed to go use the bathroom. She passed out again. What do we do with this patient? This is a 1, 2, 3. This is about a 6.5 second pause. So this patient decides to not have a heartbeat for 6.5 seconds. Who thinks that this patient should get a pacemaker? Raise your hand. Who thinks that this patient should not get a pacemaker? Raise your hand. So about 3% of you voted. But the ones that did said that this patient should get a pacemaker. Let's talk about our next friend. This is a 14-year-old that was at home and had a syncopal event. The family witnessed a syncopal event, being of course concerned. They called 911. EMS came to get this patient, and they're sitting in the bed in the ambulance, and of course it's bumping around all over the place. And one of the EMS, good intended EMS practitioners is trying to get an IV. So as they're trying to stick for the peripheral in a bumpy ambulance ride, you can see all the artifact on this ECG. The patient passes out again. This time it's a little bit different. So silly algorithm on the monitor says that it's asystole, but it's not asystole. There's actually systole. Here, 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 here. These are all P waves. And those P waves are not being conducted, right? P waves with no QRS after, we call that heart block. So this patient has heart block. Who thinks that this patient should get a pacemaker? Raise your hand. A couple more people. Two of my cardiology fellows said that this patient should get a pacemaker. Does that help anybody out? People are changing their minds now. So this is, again, asystole. Those are the P waves. This is all vasovagal syncope. So let me drive this point home. I show you those tracings because this is what has to happen, essentially, for somebody to pass out. You have to have hypoperfusion to your brain for long enough to lose consciousness, and that's a pretty significant thing. So if somebody has bradycardia-induced vasovagal syncope, then they have to have long pauses or long periods of time where the heart rate doesn't fire in order for them to pass out. If somebody stands up real fast, they have to have a pretty high vagal tone to cause vasodilation to cause them to pass out. So the only difference between these two patients and all the other patients that you've heard of with vasovagal syncope is these happen to be on a monitor, right? They happen to have ECG tracings during it to prove that that was a mechanism of their syncope. But that should not change your clinical decision about them having vasovagal syncope. So what are the hallmarks of vasovagal syncope? Trigger related. You got to know these triggers. These are so common, and if you don't understand them, it's easy to miss and think that there's pathology going on when there's not. Positional related. Somebody's lying down, their alarm goes off in the morning, they get up, they go to the bathroom, they pass out. Another scenario, they lie down, they go to the bathroom, then they're combing their hair, and they pass out. Sometimes they actually pass out while they're peeing, so don't go to the bathroom if you're a teenager, right? They can also pass out after exercise. So if somebody's running, they stop running, they're walking to the bench, then they start to feel a little woozy. That may not necessarily be arrhythmia. It still needs an evaluation. But if it's after exercise, that's different than 50 meters into a 100-meter dash. That's pathology, right? So after exercise is another important clue. And there's always a prodrome. That prodrome is the same in just about every patient. They're dizzy, lightheaded, they have tunnel vision. Sometimes their hearing gets muffled. You hear this time and time again. These are clues that there's not significant pathology going on. Oh, this is a 2-week-old post-tetralogy of repair, post-tetralogy of Fallot repair that's hanging out in the unit. This is the arrhythmia that you see. This is the most common alarm at the Cleveland Clinic for arrhythmia. My clue here is to find the QRS. So you look here and you see what seemingly a disaster. Wide QRSs all over the place. It looks like it's really fast. First thing is you assess the patient, of course. All the residents in the room know that. Somebody has an arrhythmia like this and you get called by the nursing staff. Don't say, I'm going to go back to sleep. Don't say it's nothing. Don't say, go get the code cart. Go check out the patient first. If the patient's hanging out, you got some time to figure it out. Next thing is have a high index of suspicion. So when I find the QRSs, they're there, right? They're underneath the nonsense that's going on the surface. The nonsense that's going on the surface is artifact. And you have to have a very low threshold for thinking about artifact. Not saying that something is, but think maybe this is not an arrhythmia after all. It's more likely to not be an arrhythmia than likely is to be an arrhythmia. So look for the QRSs. If the QRSs are marching through the background noise, then it's artifact. And that's exactly what this is. This is a 15-month-old baby that we saw who stopped growing, seen by the pediatrician for poor growth and was bradycardic during the evaluation of the pediatrician and was referred to us for bradycardia. And this is what the ECG shows. So the ECG here shows P wave, P wave, P wave with just a handful of QRSs. So there are more P waves in QRSs, and this is heart block. Those are all the P waves are. The QRSs are these big guys that you don't see as much. So complete heart block is the most common indication for pacemaker in pediatric patients. They can be the result of maternal antibody exposure. You all know the lupus story. And those with lupus antibody exposure tend to be more at risk for developing ventricular dysfunction and a cardiomyopathy as a result. Most cases, though, are idiopathic. So as it was in this patient, we never really found a cause for their heart block. Not because there isn't one, but we're just not smart enough yet to find out what that is. And this patient got an epicardial pacemaker. It's important to understand that there are different strategies for implanting pacemakers. This patient got an epicardial one in the belly, where the leads go on the outside because the veins in a little baby are too small for them to get the pacemaker that your grandparents may have, the one that's up here that goes through the vein. Who gets pacemakers? The indications, generally speaking, are people with symptoms from bradycardia, people with really low average heart rates, big long pauses, this is for heart block again, or those who have ventricular dysfunction. To summarize, SVT is really common in the pediatric patient. Causes of sudden cardiac death can be excluded in, or must be excluded in a patient with syncope, and history is often more useful than the ECG. Pacing and ICDs are valuable tools in the pediatric population. Not all arrhythmias are created equal. So VT does not equal VT. It depends on the patient, and it depends on the underlying milieu of the patient. And that is all.